everyone. So today's teaching session is on back pain. Um, Objectives-wise, we just want to look at the etiology and pathophysiology of back pain, the importance of taking a thorough history and red flag symptoms to look out for, developing an approach to evaluating it systematically, and then formulating appropriate management accordingly. So straight into a situation. We've been asked to clerk in a patient, a 27-year-old female, has come into SDEC reporting a 6-month history of back pain. She reports this has gotten worse over the last 3 days, and she's no longer tolerating it despite taking regular analgesia at home. Pain's also radiating down her left thigh, and she actually feels weak in her left leg. So history presenting complaints and the important things to go through, you know the mnemonic Socrates. So just working through for this patient case, site-wise, she's complaining of it mainly in the low back. It's radiating into the front periumbilical area and the groin. She's noticed it, that came on for a couple of months now, but it's been considerably worse over the last couple of days. In terms of the character of the pain, it's quite dull and constant, but she does have moments of sharper stabbing pains. It's radiating into the left thigh and kind of laterally down the lateral aspect of the thigh. Alleviating factors, she took some analgesia and just paracetamol and ibuprofen at home, but she's noticed that that's not she's not noticing any difference with that anymore, and she's actually moving on to taking codeine, but that's still not helping. It's present at all times. Exacerbating wise, it's more manageable when lying flat, so standing or kind of hinging at the hip is making it worse. And severity, it's 8 out of 10 at its worst, about 6 or 7 at rest. So again, kind of like building on that history aspect, you definitely want to get a past medical history. For this patient, she reports that she's fit and well. Drug history-wise, she's on the combined oral contraceptive. Make sure you always ask for allergies as well. Family history, there's no significant history there. And social history-wise, she's a regular smoker, kind of smokes about 5 a day and drinks 4 to 6 units weekly socially. Red flag symptoms then. So the most important things to look out for in back pain are fevers, sweats and chills. Are they having night sweats? Are they having kind of unprovoked fevers? Have they been unwell recently? Is the back pain, or has the back pain been present for more than 6 weeks? Have they experienced any weight loss? Sidle anesthesia is a very important one, so you might ask them, do they still have normal sensation when they wipe after opening their bowels? Or if they notice that they've just got reduced sensation when they're sitting down. Any episodes of incontinence, urinary or bowel. Any neurological deficits, so that will be coming from your examination. And then any recent trauma, history of cancer or history of infection. An important thing to remember with the infection there, I've listed that there is things such as diabetes, IV drug use, immunocompromised patients. So they are just going to be at higher risk. It's not an exhaustive list here, but the CKS guidelines list against all the subheadings here. So they kind of go into more detail about everything you need to know about. But these are the kind of big red flag things you need to look out for. So on examination for this patient, you assess the airway and she's talking to you in full sentences, so it's patent. Her O2 sats are 99% and you can't hear anything additionally on her chest when you have a listen. Respirate 17. And when you assess her circulation, her blood pressure is 112 over 84 and her heart rate is 74. It's regular. She's well hydrated. Her cap refill is normal. There's no additional heart sounds and there's no obvious peripheral edema. She's alert. Her pupils are equal and reactive and she's moving all 4 limbs against gravity. She has not got a temperature, her abdomen's soft. And then in the left lower limb, when you do a more focused exam in terms of her neurological exam, even though she was able to move it earlier, you notice that there's actually an altered sensation in the L5-S1 distribution with some constitutional weakness in that area too. So she's scoring about a 4- on the ankle and the big toe and the plantar flexion. So you do that further examination, and the sensation is grossly intact throughout the cervical and thoracic dermatomes. However, she reports feeling a bit of tingling and just feels a bit different when you're assessing the L5-S1 dermatomes. Like we just said, power's 5 out of 5 and all the myotomes assessed apart from in the hallucis extension, that's 4+, and it's normal in flexion. It's about a 4- in plantar flexion, as just mentioned. Reflexes are present bilaterally and equivocal, and the Babinski is downgoing. Sciatic stretch is actually negative, so you rule that out too. So investigations. Imaging is the key in this kind of situation. You're considering between an MRI versus a CT scan. We've got a scan here for you. So this is a CT, and as you can see, it's got very nicely highlighted there, herniated and bulging discs. This isn't for this patient directly, it's just to demonstrate what you're looking for. So you're looking for, if you follow the arrow, altered signal. And as you can see, so this is the spinal cord with the CSF running down, that's all white. And you can see that there's disc here, which is pushing into it and disrupting basically that flow of CSF. So it's disrupting the spinal cord in those areas. And that's what it would look like. Investigations wise, then boxes is a useful mnemonic to remember. So bedside observations, which we've already got, bloods that we've discussed, you want to send off for looking for infection markers and anything else untoward. Orifices, so for someone coming in with back pain and who has reported episodes of incontinence or any kind of paresthesia or sidle anesthesia, you definitely want to consider doing a PR. Make sure you use a chaperone when you do this and assess for sensation and tone. X-rays plus minus other imaging, like we've just discussed. ECG is always important as well for a newly admitted patient, just to give a baseline, and then we can consider special tests, such as we've just discussed here in this kind of imaging. So you look at the MRI, and just to kind of give an example of how you might request it and what you might need to tell them and what the report is. So 27-year-old female, admitted with 2 days of worsening low back pain radiating down the lateral and anterior aspects. So you're kind of explaining how old they are, how long it's been going on for, exactly where it is, what you found on the neurological assessment, which is this mild weakness in the L5S1 distribution, and important negatives as well, such as no saddle anesthesia. And then it's always really helpful if you've obviously formed a bit of a differential and you're kind of diagnosing as well when you're there. So if you can give that differential to the radiologist, it really helps guide them in terms of what you're thinking and looking for. So you put there at the end of the request, query disc herniation. Report comes back as at the L5S1 level, there is a disc protrusion with compression of the exiting nerve root and associated altered signal. There's no facet arthropathy, which you'd expect in a patient her age. However, so you've got proof there that there's a disc protrusion and that's actually impacting on the nerve roots in that area at that level. So talking about differentials for low back pain and acute low back pain, this is a really useful flowchart to follow, so feel free to pause and have a look through. But essentially, only 5 to 7% will present with significant neurological deficits, and the first thing you want to kind of query and alarm bells need to go off for is cauda equina. Another thing you can look at is sciatica, and otherwise central canal stenosis. So cauda equina, we're ruling that out by asking about the sidle anesthesia, the incontinence, and looking at the weakness. Sciatica, we did the stretch test, and we know that that was negative. Non-specific low back pain tends to be 90% of cases who present, and there's no obvious pathoanatomical diagnosis here. So you basically are reassured by the absence of red flags. And a couple of percent is actually serious or systemic pathology. And that can be, again, kind of going back to the causes we looked at earlier. So malignancy, systemic disorders, infections and fractures are all important things that you need to look for and manage urgently because they can progress quite quickly. Again, just kind of building on these differentials, another really useful table taken from Strong Medicine and Dr. Eric Strong. And it just kind of goes through all of those different things in a bit more detail. So again, feel free to pause and have a little read through this. It's just looking at those more urgent issues that you need to consider, and also some more referred pain types of presentations of low back pain. So that's always important to remember those as well. It might not necessarily be spinal pathology. So aortic dissections, pancreatitis can often present as back pain, and kidney related issues can also cause referred pain in the low back. Plan wise, so what you're going to do. Key to explain the diagnosis to the patient, especially a younger patient who's presenting like this. They're going to be very anxious, most likely, so they're going to want to know what's going on, why they're feeling weak, why they've got these symptoms. So it's always helpful if you can explain the result findings to them. So if you've got the scan results back, talking to them and kind of going through this. If you don't feel comfortable doing that, then speak to a senior first who can help assist you with this. Making sure you get some pre-op bloods. So the initial bloods for infection markers and kind of screening. So you've got an initial set, but also if they are likely going to need some form of neurosurgical intervention, discectomy in this situation. So it will be helpful to prep them for theatre by doing the normal pre-op workups. So bloods, group and saves, and an ECG. Making them nil by mouth and prescribing IV fluids for overnight or during the day because they're likely going to be waiting for theatre intervention. And then discussing the case with a senior, with the neurosurgeons if you're not on a neurosurgical ward. If you are working on neurosurgery, then obviously just directly discussing with your registrar because the patient will need consenting and listing for theatre. And that will be all the basics and will mean that you've covered all your kind of essential parts and been a real help to the team.